Hey, everyone. Oh, we have some feedback here. Let me fix that. This was on. It was muted already. It's muted. Hello? 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 Oh, you have to turn the volume down. Hello? Good. Well, it's so nice to have you all. Welcome back after our summer hiatus. It's so nice to see our students here with us today. As many of you probably know, this series is about 10 years old, and we started this when this campus was really just sort of in its infancy, and there weren't many people here. Number one, to be really truly a community resource for our neighbors to come and learn from some of our healthcare providers. So we have covered in 10 years so many different topics I couldn't even tell you, but this is one of my favorite presenters that's here with us tonight. And also we wanted to bring more people into the community that didn't yet know about Roseman, knowing that our College of Medicine was being built from the ground up and was an idea back then 10 years ago. And look where we are today. We have our first cohort of students, and some of them are back here joining us. And we have a number of guests on the Zoom with us again tonight. So with that, before I get started, I just would like to introduce Craig Fraley from Clark County Credit Union. Without Clark County Credit Union, we wouldn't be able to do what we're doing here tonight, and he's been a wonderful community partner, and we're incredibly grateful. So let me turn it over to him real quick.
Thank you, Vanessa. Good evening. Most of you have seen me before, but for those of you who haven't, I'm the Director of Business Development for Clark County Credit Union. We are the medical filled credit union. We're basically the credit union for policemen, firemen, medical, but anybody can join. And I just want to highlight something that's really cool is we're owned by our members and we're not for profit. And we pay some of the highest interest rates on our deposits in the country. I've got some magazines out there, so take one of these before you leave. Don't wait for the movie to come out. It's a good read. But we have a checking account that pays up to the first $25,000, 4.07%. Highest rate in the country on a checking account. So I tell people if you have money sitting somewhere, it's earning less than that, you can just park it in that checking account. It's completely liquid. And the whole time it's in there, it earns 4.07%, which is a great rate. So enjoy the presentation tonight and have a wonderful evening.
Thank you, Craig. So we are recording this, so we always record these and post them to our Neighborhood Health Series page. So anyone that missed something, you can always access that recording. We will hold questions till the end, and I will field the questions for Dr. Lasky as well as the questions on Zoom. And again, we're incredibly happy to have him here. And before he presents, I have to introduce him and tell you a little bit about him because he's so very impressive. So Dr. Lasky is the medical director of Cure for the Kids Foundation, which is in this very building, as you know. He became that in 2017 as the director of Neuro-Oncology. He attended medical school at the University of Illinois at Chicago and did his pediatric residency at the University of Chicago. He completed his pediatric hematology oncology fellowship at UCLA in 2006 and was director of the pediatric neuro-oncology program at UCLA until 2009 when he moved to Harbor UCLA Medical Center in Torrance, California, and was named chief of the division of pediatric hematology oncology. While there, Dr. Lasky became involved with a number of clinical trials for patients with bleeding disorders, including hemophilia and von Willebrand's disease, as well as sickle cell anemia. While continuing to have research interests in pediatric brain tumors and immunology, he also is interested in running and developing clinical trials for patients with bleeding disorders and sickle cell anemia. Dr. Lasky is a member of several professional societies, including Children's Oncology Group, Society for Neuro-Oncology, American Society of Hematology, and the American Academy of Pediatrics. He enjoys watching sports, reading, music, and outdoor activities with his family. Please join me in welcoming Dr. Lasky.
Thank you. Can you all hear me okay? Okay, very good. So my name, as was said, my name is Joesph Lasky. I'm a pediatric hematologist, oncologist by training, but I'm also the medical director now of Cure for the Kids Foundation, which is a clinic based right here in this building upstairs. And now we are expanding into some first floor space too. I know the med students have probably noticed the construction going on. And so we're definitely an expanding organization. And we not only have pediatric hematology oncology, we also have pediatric rheumatology, we have genetics, we have pediatric orthopedic surgery, we have behavioral therapy, and we have physical therapy. So it's very much a multi-specialty clinic that again, focuses on kids, but we actually do take care of young adults and some older adults as well for a variety of different rare diseases. The topic that was titled for me, I didn't necessarily choose it. It sounds a little ominous, I think, but childhood cancers, light in the darkness. And I thought it was kind of interesting, on the advertisement, the flyer, they had this picture, which I thought was a little creepy, of a guy in the woods. And this is not me. And so I thought it was very similar to this old Conjuring advertisement. But anyway, so I'm not here to scare anybody, but in any case, and my only disclosure is that I'm a Chicago Bears fan. So sorry about that, but anyway. All right, so to get started, I'm going to talk about a whole breadth of things involving childhood cancer. And before I start, I am going to make a shameless plug for pediatrics, and we have a pediatrician in the room as well. And so pediatrics is the better specialty. I have to say, we also need people to take care of our more wise people in the population, but pediatrics is still my bias, and of course pediatric oncology is what I hope you will all go into, but in any case, that's my shameless plug for that. So some objectives, I'm going to talk about current epidemiology and statistics of childhood cancer. I'm going to talk about presenting signs and symptoms of childhood cancers, and also make kind of note of how similar those symptoms can be to regular childhood diseases. And so separating those two things out is the challenge of any general pediatrician and any emergency room. And then finally, I'll finish with understanding some of the current therapies for childhood cancers and then their outcomes. So, thinking about the impact of childhood cancer on, public health. As we all know, the leading causes of death in children and teens in the US are the following. So accidents, of course, So accidents, of course, are the big one, and then suicide and homicide, unfortunately, are the next two. And then fourth, if you look at all children and teens, is cancer. However, it is the #1 disease-related cause of death over the age of 1 year old. And if you look at that a little more in detail, this just divides things up into the younger kids 1 to 14 and the older kids 15 to 19. And so the adolescents definitely have accidents, homicide, and suicide as their tops. And then comes the malignancies. But in the younger kids, 1 to 14, cancer is just second to accidents in causes of death in that population. So cancer is definitely a public health thing for pediatrics. It's again one of the leading cause of disease-related death. However, how common is pediatric cancer? And in the scheme of diseases, if you include adults and kids, it's still a rare disease. And it does afflict 15,000 new cases per year in the United States, and probably about 200 to 300,000 new cases worldwide, again, pediatric cancer. But it's the leading cause of disease-related death in the developed world. Obviously, in developing nations, there are other causes of death, infection most notably, that lead. But we can compare this to other childhood diseases. So type 1 diabetes is about 18,000 cases per year. Epilepsy or seizure disorder is about 30,000 cases per year. So relatively similar. But then you get into the common diseases that a pediatrician or an emergency room or an urgent care might get. And so ear infections are more than 5 million cases per year. And stomach bugs and gastroenteritis is 1.5 million cases per year. So those are obviously way more common than cancer in kids. And so obviously separating out things, that could be cancer, it can be very, very difficult. So now I wanted to just compare it to adult cancer, which is way more common. So if you take, males and females together, that's 2 million new diagnoses of adult cancer per year. So 15,000 compared to 2 million. Obviously, adult cancer is way more common of a disease. And that, unfortunately also goes into how our healthcare system and how our pharmaceutical system develops drugs for cancer. In other words, they want to treat adult cancer because they make way more money than treating children's cancer. So unfortunately, we have a lot less new therapies being made for children's cancer than we do for adult cancer. And I'll talk about that a bit too. So, you know, I had commented on childhood cancer being a rare disease as compared to common childhood diseases like infections and stomach bugs and so on and so forth. And so there are a lot of challenges in trying to separate out, you know, one or the other. And, you know, so one of those is, you know, I talked about, you know, the rarity of cancer and symptom overlap. And so, you know, it's just a fact that childhood cancers are rare. And so doctors and parents are going to suspect more common diseases first. Fever, fatigue, bone pain, swollen lymph nodes can often look like, you know, infections. Growing pains in the bones can, you know, growing pains can be normal. They can also be a symptom of cancer. The signs and symptoms can be very nonspecific and subtle. So, you know, everyday illnesses can be usually just an everyday illness, but they could also be signs of cancer. Leukemia can appear to look like a viral infection. Brain tumors can just be behavioral changes, or you're not doing as well at school. And then, of course, you know, young kids, it's, you know, if they can't verbalize what their symptoms are. A teenager is going to tell you if their leg hurts or their stomach hurts or their throat hurts, but a 2-year-old is just going to be irritable and not be able to really tell you. So that can all be very difficult to sort out when making these diagnoses. Some other, you know, limitations, there's access and system constraints, you know, as many of us who've practiced in the Las Vegas area know. We have a limited availability of pediatric specialists. We have a limited availability of certain types of imaging, certain types of procedures that can get done. So that's a challenge in this community. And we're slowly getting better and getting more availability of those, but it's been slow going. And having more medical students at medical schools in town is going to help that shortage. We also have issues with delays from insurance companies and getting approvals for a variety of tests. And then, you know, we, at least at this point, do not have a consolidated children's hospital, although one is probably going to be built in the next 5 years. But, you know, it's sometimes just hard to get all of the subspecialists in one room together to talk about cases and figure things out. And then finally, you know, psychosocial factors, you know, parents may not want to admit that their child could have cancer, and they don't want to be perceived as overreacting. And we want to empower parents, of course, to ask the questions and be an advocate for their child. And then, you know, clinicians also, though, need to be cautious. They don't want to get too many CT scans on a kid who really is just having a normal stomach bug. But you have to, again, weigh the risks and the benefits and really look for the signs that are pointing towards a more ominous thing. And then finally, you know, aggressive disease biology, just to, you know, pediatric cancers often grow faster than adult cancers. And we want, you know, we want to diagnose these in an expeditious fashion because early or late diagnoses can result in poorer outcomes. So this just gets to my point of, you know, separating out rare things from common things. Some people might see a young woman, some people might see the old woman. Same thing, is it a horse or is it a frog? So, but if you turn your head, it can be a horse. So anyway, so again, separating out rare things from common things can be difficult. Okay, so I've been talking about childhood cancer. So what are the cancers that kids get? So like I said, it's, you know, the second most common cause of death in the ages 1 to 14. This is a picture of cancer and incidence of ages 0 to 19. So again, this is babies to young adults, really. And you can see the top 3 are right here. Okay, so leukemia, lymphomas, and brain tumors. So those are your top 3 cancers in children. And then there's a whole bunch of different types that are a little bit less common. I do want to point out that if I made this pie and I said only 0 to 14, it would be a little bit different. The main thing that's different are these things, melanomas and epithelial neoplasm, so basically skin cancer. So we're actually seeing an increasing rate of skin cancer, mainly melanomas, in 15 to 19-year-olds. And so that's actually what this big orange pie is here. And in general, they're not malignant melanomas. Usually the oncologists never see them, just the dermatologists see them and get rid of them and they're cured. But it is a significant, again, cancer that our young adults are getting now. So it's important for skin exams to be done. So where do these cancers occur? Well, the most common forms of cancer in children, which are the blood cancers or leukemias, occur in the bones, or in the bone marrow specifically. And so this is just a cross section of a bone. It has this kind of, compact, hard area on the outside, and then in the inside is what's called the bone marrow, and there are lots of blood vessels and fat and stuff in the bone marrow. And it's there that the main cells of the blood system are made. So you have stem cells, you have red blood cells, you have the infection fighting cells, the white blood cells, and then finally the little cells that help your blood clot, or the platelets. And where is the bone marrow in the body? Well, it's wherever there is bone in the body. And so when we talk about diagnosing leukemias, we usually talk about doing a bone marrow biopsy. So we usually do that in the biggest, thickest bones of the body, which are the pelvic bones. And so those are pictured here. And so that's usually where we sample our bone marrow. So where else can cancer happen? So the lymphomas, of course, happen in the lymph nodes. And where are lymph nodes? They're all over the place. So in theory, you could get a lymphoma in any part of the body. The most common, places for, young adult lymphomas are going to be in, the head and neck and the chest area. So that's where your Hodgkin lymphomas are going to happen. There's another form of lymphoma called non-Hodgkin lymphoma, or Burkitt lymphoma in children. That usually happens in the abdomen, but technically they could be anywhere. And then finally, the rest of the, tumors that I kind of talked about can happen anywhere. I told you the third or second most common malignancy in kids are brain tumors, but they can get tumors in the muscles, they can get tumors in the liver and the kidneys. They technically can get them in, the pancreas and the intestines, although those are much, much less common than in adults. So your top cancers in children are usually muscles, kidneys, and liver. Again, those are going to be your top kind of organs for where children get cancers, besides blood and the lymph nodes, which are the most common places. So what are some red flags that pediatricians and urgent care and parents need to look out for? So, we get referred a lot of, times for persistent fevers, or fevers that aren't going away. Usually just isolated fever alone is not a sign of cancer or leukemia or anything like that. Usually there are other symptoms that go along with it. But if it's a fever that you really cannot find an origin for, if it's not a sinusitis or a lung infection or a urine infection, sometimes you may need to go a step further and look, either in the bone marrow, or at least check a blood set of blood counts. Weight loss from high metabolic demands of cancers, fatigue, which is again a very generalized symptom, and then pallor or bruising, which can be due to anemia or low hemoglobin, or low platelets. When your clotting cells are low, you can bleed. And again, those are often signs and symptoms of leukemia. Just some other general symptoms. So I already talked about leukemia with fatigue, bone pain, and bruising. Brain tumors can be headache, vomiting, gait disturbance, or sometimes even just behavior changes. Lymphoma, again, you're usually going to have lumps somewhere. Usually it's going to be neck or groin, and can also have weight loss and night sweats with that. Sarcomas, which are solid tumors, usually happening in the muscle or the bone, so that's going to cause swelling in those areas. Some of the most common abdominal tumors of childhood are Wilms tumor, which is a kidney tumor, and neuroblastoma, which is a tumor of the adrenal glands, and that can form masses in the abdomen. And then finally, just to touch on germ cell tumors, which can occur in infants, and there's these tumors called teratomas that occur in infants. But there are testicular tumors and ovarian tumors that occur in adolescents, called germ cell tumors. And in males, germ cell tumors are actually the most common form of cancer between the ages of 15 and 40. So examining the testicles of these, of a kid who comes in with leg pain is very, very important, because it could be testicular cancer. So I talked about, just signs and symptoms and stuff that a parent or a pediatrician are going to look for. I'm going to just touch on some common imaging studies that would be done when we need to look a little bit further. I just thought that was a cool picture. So plain X-rays are the most common form of X-rays that are done. We actually have a machine in this building that can do plain films for our kids, mainly for our orthopedic surgeon, but they can look for fractures, of course, but they can also look for pathologic fractures due to bone tumors or metastases from other tumors. Some of the sarcomas, mainly there's one called an osteosarcoma, which is one of the most common bone tumors of children, can have classic appearances that on plain films that you can make a diagnosis based on just a regular X-ray, but you usually still jump to further imaging. Ultrasounds are another methodology we use a lot. They're really good because they're really fast. They don't have any radiation. So they're often used to look at lymph nodes or to look at thyroid masses, which also happen in adolescence. This is just some plain films. That is an arm and a normal hand, nothing wrong there. This is a chest X-ray showing lungs and a normal heart. This is an ultrasound down here of an abnormal lymph node. And so those are, again, kind of our first line studies that might be ordered by, again, a pediatrician, urgent care, or emergency room to start the workup for a tumor or for, bone pain or fevers in a child. And then kind of a step up from there are your CAT scans, as we call them, or CT, computed tomography scans. So these are really good at visualizing lymph nodes in the neck and upper chest areas. They are the best type of scan to look for lung metastases or lung nodules or other abnormalities. In general, they are done with IV contrast, which, again, for young children is a distressing thing to have an IV put in, but again, that's going to give us our best pictures. But with modern equipment, most of these scans can be done quickly, and so even little kids can often sit still long enough to get really good pictures with CT scans. And so if you go through the records of emergency rooms, this is going to be one of the most common things ordered in an emergency room. There are situations where we like to give oral contrast, which can give better visualization of the abdominal organs, but we usually don't need to use that, especially with little kids. It's really hard to get them to drink stuff. This is just a picture of a CT scan with kind of a cross-sectional coronal view. And you can see the organs all show up really nicely. You have your liver, and the kidneys are further back. You don't see them, but here's your intestines, your stomach, the bottom parts of your lungs, the heart. So it gives very nice detailed pictures of the organs and the blood vessels itself, the vena cava and the aorta. So CT scans, again, pretty good detail, but still not as much detail as we get from another type of scan called an MRI, which I'll get to next. I did want to point out that CT scans do use radiation. And, kind of right here is this, there's this measurement of tissue exposure called sieverts or millisieverts. And you can compare it to, a regular chest X-ray is 0.1, a full body CT scan is 100 times more, or 10 of these millisieverts. However, if you do a whole lot of flying during the year around the country, you're going to get almost as much as a CT scan. So we do get natural radiation from just flying. We also get natural radiation over the year just from being outside. So obviously, we don't want to do too many CT scans, but when we need to get a diagnosis, we sometimes have to bite the bullet and get a CT scan. And modern scanners actually use less than this. So it's actually at least half as much now. And then you can see that compared to what you'd get from hanging around nuclear plants, which is a lot more. So again, then after CT scan, the next step up is magnetic resonance imaging, or MRI scans. So this is by far the best for imaging the brain and the spinal cord. CT scans can only give you so much detail, but for brain tumors and for other abnormalities of the brain, MRIs are definitely the way to go. They're usually done with IV contrast, but can be done without. And whether it's the brain or even the abdomen, the surgeons usually want to follow up any CT scan with an MRI to get a little bit better view for planning complicated surgeries. One of the big problems with MRI is that they take a long time and you need to sit really still. They're very sensitive to movement. And so the kids oftentimes need to be sedated or made to sleep while they're getting the scan. And even some adults require sedation to sit still for some of these scans, to tell you the truth. And then the other situation where we do get this is even if we see something on a plain X-ray, an abnormality in the bone, sometimes, again, for biopsy purposes, we get an MRI to get a little bit more information about knowing whether a lesion might be benign versus malignant and needs a biopsy. So we in oncology order a lot of MRIs, and that's one of our main scans that we do order. This is just a side picture of a brain MRI. This is your brain stem, your cerebellum, the back part of the brain, and then your cerebrum is the top part of the brain. And this big gray part's your tongue. It's way bigger than we think. So anyway. And then finally, kind of another step up in technology, something a little bit newer are some of our nuclear medicine scans. And one of the common ones, again, we order in oncology is called a PET-CT, which stands for positron emission tomography computed tomography scan. And one of the main reasons we use these is to actually determine tumor response to therapy. And we use this in the lymphomas and the sarcomas. And basically you can, after treatment, if you do a CT scan of some of these tumors, you're still going to see a mass there, but you don't know if it's dead or alive. And these PET-CTs can help you determine whether it's dead or alive, and whether or not you need to get a biopsy again, or you can just watch it. And so this helps us a lot, again, in post-treatment follow-up. And the way it's done is they do also require an IV, and they actually do inject a radioactive glucose that then gets taken up by active tumor cells. And then the scan can kind of look like this. So brain always takes up a lot of glucose, so it's always really bright. That doesn't mean there's a tumor there. And then the kidneys always take up some, and the bladder at the bottom that's covered up by the images there takes up a little bit. But this, again, so you can see the vessels are actually lighting up, but I think this patient may have a pancreatic tumor, and it's kind of subtle, but that, anyway, with lymphomas, it's a lot more dramatic, where you see the big lymph nodes lighting up in the neck and stuff like that. But so we, again, in oncology, order these scans quite a bit. Okay, so to get back to the common forms of cancer, let me see what I was talking about. This last part of the slide, I'm going to talk a little more about treatment and outcomes of the pediatric malignancies. And so again, just to refresh you on the types of tumors that kids get. So again, the top three are leukemias, lymphomas, and then brain tumors. And then I told you about muscle tumors or the rhabdomyosarcomas. Germ cell tumors are your testicular and ovarian tumors that happen in adolescents. Neuroblastomas are abdominal tumors that happen in infants. Bone tumors, so these are generally bad ones to have, so that's osteosarcoma and Ewing sarcoma. Kidney tumors are the Wilms tumor, there are liver tumors. Retinoblastoma is very rare, but it has quite a dramatic presentation, so this is the most common eye tumor of childhood. Again, it's very, very rare, but very important for pediatricians to look and do what's called a red reflex, where they look into the eyes and make sure they see equal red shining out of the eyes of the infants, because if one of them's white and one of them's red, that could indicate a tumor in the eye, and that's what you look for retinoblastomas. All right, and then just a quick genetic biology lesson, and medical students are learning about a little bit about this. So, I mean, we all know the progression from genes to protein. So again, our genes are encoded in DNA. We all have, 46 of them in our cells, 23 from mom, 23 from dad. And then there are genes on there that get transcribed into this other thing called mRNA, and probably some of you hear about mRNA because we have mRNA vaccines now. Again, all of this is related. And then finally, the mRNA gets translated into proteins that are the workforce, okay? And here's our chromosomes. So again, 46 total, 23 from mom, 23 from dad. Women have double X's, men only have a stumpy chromosome. So we're inferior, I think, because of that, but that's okay. Okay. Some other terminology just to note. We talk about germline mutations, and we talk about what are called somatic mutations. So cancer in general is due to somatic mutations. In other words, mutations that occur after a person is born. Now, there are a number of genetic syndromes that are germline mutations. In other words, syndromes that a person is born with that can predispose you to cancers. But usually that predisposition isn't enough to give you cancer. In other words, you might have a predisposition, but then you need something else to happen to really set the cancer off. And this is the same thing. So be it, BRCA1 and BRCA2, the breast cancer susceptibility genes, those are germline mutations. So you're born with those, but obviously even someone with those mutations don't get breast cancer in childhood. It takes until adulthood for them to get cancer, but they get it earlier. Now, there are some germline mutations that do cause childhood cancer early. There are diseases like Li-Fraumeni syndrome and neurofibromatosis that are tumor predisposition syndromes. And so those are germline mutations, and we follow a lot of patients with those syndromes in our clinic. So besides genes causing cancer, what else contributes to cancer? And the short answer is we don't really know all the things that cause cancer, but we have a number of things that are associated. So this is a very long list and the words are kind of small, but I just kind of wanted to show you the breadth. So there's a lot of yellow on here, which means inconclusive. And so this separates out a number of childhood cancers. So leukemias, neuroblastomas, Wilms tumor, and these last four are different types of brain tumors. And you can see, so smoking, is associated with ALL, is associated with some abdominal tumors. And then, so in other words, there's a whole number of different things that potentially can contribute. Green means it makes it better. So we can see that breastfeeding actually decreases your risk for some cancers, for a lot of cancers. Actually having allergies decreases your risk for some cancers, which is kind of an interesting phenomenon. In any case, so again, all of these are associations. They're not really causative, but lots of research going on into what contributes to cancer development. Okay, so this, I just think it's kind of a cool picture that talks about how different cancers occur at different ages. And this kind of applies to adult cancers too, but for the most part, adult cancers occur, the older you are, the more cancer you get. And there's a little bit of that happens in childhood cancer too, but there are actually some unique kind of peaks and valleys in childhood cancer. And one of the main ones is the leukemias. So the leukemias in childhood are the bottom blue part, and those are highest in the toddlers. So 2 to 5 is your peak, and then the leukemias kind of go down a bit. And then the other thing, these tumors called embryonal tumors, that's this orange-yellow color here. So that's like your liver tumors and your adrenal tumors, so neuroblastomas, kidney tumors. Those happen in infants and toddlers, and then they kind of go away. And so it's just kind of an interesting thing that, the risk for a particular type of childhood cancer changes as you go from 0 to 19. And you can see the green, which are other solid tumors, and then the bone tumors. Those definitely are much less common in infancy and young childhood, and they increase in the adolescent age group. So again, different ages get different cancers. So one of the kind of positive things to talk about with regards to childhood cancer is our overall survival. So ALL doesn't mean all, that actually means acute lymphoblastic leukemia. So this is leukemia overall survival. And it's kind of a cool graph. So this is all data from big studies that were done in the past. And so these were the original data from back in the 1960s and 70s. So this is survival. So, I'll just put it here. So 6-year survival, less than 10% back in the 1960s and 70s. And now come to 2010 and 2015, we're up over 90%. So we have gone from almost no survival to over 90% survival for acute lymphoblastic leukemia. So that's been, just some awesome progress made between, again, the 1970s and now 50 years later, the 2020s. And that's really been the success of a particular research group known as the Children's Oncology Group, based in the US. And then there are European and other groups as well that have carried on this work. But childhood cancer research is incredibly important. It's the only way that we've been able to have these types of successes. And so, based on that, I wanted to give you a little idea of, how did we treat, leukemias way back here, okay? And so, first of all, lymphoblastic leukemias accounts for about 30% of childhood cancers. That's, it's the biggest slice of the pie. Until about 1960, it was invariably fatal. It was a death sentence. And so the initial goal back in the 1960s was they just wanted to induce remission, meaning they just wanted to get the cells out of the blood and make them disappear. And so that happened, again, way back in 1948. There was a drug called aminopterin, which was a precursor to this drug called methotrexate. And it was used by this guy, Sidney Farber, which is now Dana-Farber Cancer Institute in Boston. And it was found that they could give it to kids with ALL, and it induced remission in 40% of children with ALL, meaning they could give the kid this drug and it would make their leukemia be undetectable. Now, undetectable those days is different than undetectable these days. In other words, we have way more sophisticated methods to detect cancer. Back in those days, all they could do was do bone marrow biopsies and look at it under the microscope. And if it was there, it was there. And if it wasn't, it wasn't. And now we can do a lot of molecular testing nowadays that is more sophisticated. But in any case, this was the start of modern leukemia therapy back in the 1950s. And then over time, there was another company, these guys, Hitchings and Elion, that was in the Burroughs Wellcome Company. They made this drug called mercaptopurine, and that was used at Memorial Sloan Kettering, again, to induce remission in kids with ALL. So the problem with these drugs is you could give them the drug and you could keep giving it to the kid, but then eventually the leukemia would become resistant to the drug and the leukemia would come back again. So then they decided, well, let's keep making new drugs so we can overcome this resistance. And in the 1950s, they first synthesized a synthetic steroid called prednisone, which of course, all of us probably at some point in our lives have been on prednisone for an ear infection or a sinus infection or asthma. But it's the same old drug, again, very good for leukemia. And this was just kind of showing what leukemia looks like. So this is like number of cells in the body. And so you may not have any symptoms of leukemia until you've reached 10 to the 10th cell. So 10 to the 6th is a million. So this is like a million cells before you even know that you have leukemia, okay? And so then you're gonna present to your oncologist and you're gonna give a drug and it's gonna get you down to here. But then some of these cells are gonna be resistant and then you're gonna relapse. And so we need to find something to give right here to make it go down to zero. So that was the challenge of the leukemia treaters back in the day, and it's still a challenge now. And so they continued to invent more drugs. So they invented this drug called vincristine, which is a common drug we use still. It's from the periwinkle. I think it was originally used for diabetic cows, but it didn't really work for the diabetic cows, but it worked for childhood leukemia, interestingly enough. And then the Children's Oncology Group, kind of its precursor, the Children's Cancer Group, found that by combining 3 drugs together, they could start to potentially cure some kids of their ALL. And so that, again, was kind of the start of when we could actually cure these kids with leukemia. And then basically we've just gone from there. St. Jude's came into existence in the 70s and 80s and started to do their own cancer research studies and discovered that you could add a second phase of therapy, and that did a little bit better. And then they discovered that you could add other chemotherapies into this. Cyclophosphamide is a drug we use. It was related to nitrogen mustard used in World War II. So again, not really good for people, but cures leukemia. And we added more facets to the leukemia therapy. And then finally, we get to kind of our modern approach to treating acute lymphoblastic leukemia. And so I have oh yeah, there, I have a maintenance phase there. So you can see the first phase is like a month, and then the second phase is a month, and then you have like 2 months, 2 months. So it's like 6 months of intensive stuff. And then there's this phase called maintenance that lasts for 2 years, okay? So these kids, even though in the initial parts of therapy, it's kind of intense, this last part is actually relatively mild. It's still not that mild, but oftentimes these kids can go back to school at least, and interact with friends, and their immune systems are still affected, but not as much as they are in this initial phase of therapy. So in any case, so that is standard therapy for ALL, and this is the type of therapy that we still give today, even though, again, it's been around really for the last 30 years, and we cure over 90% of kids with most forms of ALL. And so we do pretty good. So what do all those drugs do? You don't need to memorize this. The medical students do, but basically, most of it all comes to inhibiting DNA synthesis. And so you can see all these drugs that I had up there are in some way or form. Ultimately, they inhibit DNA synthesis. Okay. So how do we treat other cancers? So that I was talking about, that was standard therapy for acute lymphoblastic leukemia, or ALL. A much more rare form of leukemia is AML. And then there's brain tumors, and there's Hodgkin lymphomas, and there's non-Hodgkin lymphomas, and Wilms tumor, and neuroblastomas, and osteosarcoma. And again, I'm not showing you this because you need to memorize them, but I'm kind of showing you that all of the drugs that are in this picture are the same ones we use for all of these cancers. And they were all drugs that were invented 50 years ago, and we're still using them. And they work. And so we're a little bit victims of our own success, because we've been using these drugs for so long, and we have pretty good data for most cancers. However, they're not the best drugs to use. They cause lots and lots of side effects. They obviously cause hair loss and nausea and vomiting, but they cause fertility issues, they cause endocrine problems, growth issues, cognitive issues. And so we're trying our best to figure out ways to integrate newer medications, more targeted medications, more personalized medications into the treatments of kids. But we're really still at the very beginning of that. So incidence and survival. So this is a recent slide, and so you can see, I mean, the numbers are still small. So this is incidence per 100,000. So we're looking between 0 and 3.5, let's say. And so the most common cancer is this red bar here, the leukemias. So there has been an increase between the 70s, the 1970s, and now. And the exact cause of that increased incidence, I think, is not exactly clear. We don't know if it's diet, we don't know if it's environmental changes, but there does seem to be a slight increase in certain forms of pediatric cancers. And really, it's these top three. So it's the leukemias, brain tumors, and then some of the lymphomas. The rest are pretty stable. So the solid tumors, the bone tumors, are pretty stable. But again, the leukemias, the lymphomas, and the brain tumors do seem to be increasing a little bit, not by much, and that's obviously, worrisome to us. And so we're trying to figure out why those things might be, and whether it has to do with, Western lifestyle, or who knows what's going on. But again, it's something that's actively being studied. So how about survival? So these are kind of analogous to that ALL graph that I showed you. So you can see at the bottom here, if they're small numbers, but blue is a long time ago, and then the most recent study intervals are that color. Maybe it's lavender. I'm colorblind, so I don't know what that is. But basically, the point is that we've had success in getting better at curing pediatric cancers. So the leukemias, like I said, have gone from near 0 up to over 90% for a lot of them. The lymphomas have always been a little bit more curable, but we've increased our rates from the 70s to the 90s. Brain tumors are still an issue. We're probably from about 50% to the 70%, but we could do better. Neuroblastomas, we've made a lot of progress in. Retinoblastoma is the eye tumor, again, pretty curable. So we're making some progress, but especially for things like these sarcomas, we're still down mainly in the 70s. We haven't made as much progress for those as we have for the leukemia. So still a long way to go for a lot of different cancers. Now, all of these curves are still better than colorectal cancer, pancreatic cancer, ovarian cancer in adults. They still have even more to go than we do, but we don't think any child succumbing to cancer is acceptable, and we're going to do our best to make that not happen. So I had talked about kind of the drugs we use being 50 years old, and they inhibit DNA synthesis. They have lots of late effects. So just to, show some of those examples. So growth hormone deficiency, which is usually caused by kids, who need radiation for brain tumors. Cognitive deficits, again, generally due to kids who have brain tumors and need radiation to the brain. Psychosocial issues are caused by all of our cancer therapies, and that has to do with the stress of, having to take care of a kid, taking off from work, having other children to take care of. There's a whole multitude of things that go into, just stress on the family from childhood cancer. Hearing loss, thyroid issues, heart damage, lung damage. So all of these are things we have to, look out for. And as part of our, cancer treatment program here, and pediatric programs around the country generally follow the same model, is even when a kid is done with cancer, even if they finish their cancer therapy when they're 16 years old, they still get followed by that group, often well into their 20s and young adulthood, to help look for some of these treatment-related side effects. But that being said, we still have a great need for adult treaters to be aware of these side effects, so that if they get a 40-year-old survivor of childhood leukemia, that person might be at higher risk for heart disease or kidney disease or lung disease, and the internist needs to know what they went through as a child, now that they're a survivor of cancer. And we're just starting to have those survivors. We just started curing cancer 30 years ago. So those kids who are cured are only getting into their 30s and 40s right now. And we're learning more and more that they are having early, like I said, heart disease and diabetes, type 2 diabetes, and a lot of other metabolic things that usually would have happened a little bit later in life, but are happening earlier in life. So those are things we need to be aware of. So to finish up, I'll talk a little bit about new therapies. Like I said, the chemotherapies we've been using have been around for decades. And so it would be nice to have some newer, personalized, more targeted therapies. So this actually is a list through 2021 of drugs that have been approved just for pediatric patients, okay? And we can count them. It's, 1, 2, 3, 4, 5, 8, and some of these are duplicated. So I don't know, maybe it's 15, maybe it's 20. Okay, so that's over the last decade, maybe 20 drugs approved for pediatric cancer, as opposed to adult cancer therapy, which has had probably over 300 drugs approved for adult cancers. So pediatrics is kind of left in the dust when it comes to approval for drugs. But again, we're doing our best to try to integrate some of the adult medications into pediatric therapy. And most of these medicines that are on this screen are also approved for adults as well. It's just they took a long time to get approved for pediatrics. So again, just something to keep in mind, that even though we are getting some new drugs made for pediatrics, it's still kind of at the bottom of the list when it comes to pharmaceuticals doing their research, and we'd like to try to make that more. So what are some of these newer drugs? A lot of them are kind of immune therapy based, and I truly do believe that immune-based therapies are going to be the treatment of the future. Right now, they're a little hard to do. In other words, they need, like, if you have to manipulate cells, you have to do it in a big academic center, in a lab. Like, they're hard to scale up. And but some of these drugs have been able to be, again, produced and mass produced and FDA approved. And so these are some of them. Rituximab has been around probably for about 20 years now. That's used for lymphomas. This one called dinutuximab is used for neuroblastoma. It's an antibody hooked to another molecule that helps to bring immune cells to attack the cancer. Blinatumomab is a very exciting one that's been out now for about 10 years, but it's shown some really great results in treating B-ALL. And I think it's going to enable us in the next 10 years at least to be able to get rid of some of the old chemos and maybe replace it with these newer immune chemos so that we have less side effects. Inotuzumab, so you can see they all have AB at the end. So these are all antibodies that then bind to something on the tumor cells and then kill the tumor cell. So this is what we'd call passive immunotherapy. And then even more and then another form of therapy is, so I had said these kind of are antibodies that seek out tumor cells and bind to them. And then this is kind of another paradigm of therapy where you stimulate the immune system to be overactive to try to go attack cancers. And so there's these drugs called checkpoint inhibitors, and these are advertised a lot. Keytruda and Yervoy, you'll see advertisements for those all the time for adult cancers, but they are being used in some pediatric malignancies as well. And then finally, kind of the newest forms of immune therapy that have most recently been FDA approved is what's called CAR T, or chimeric antigen receptor T cell therapy. The one that's being used in pediatric ALL is called Kymriah. We're in the process of being able to do that here in Las Vegas for kids. We're not quite there yet, but we're very close. They have used it in adults, I think, up at Mountain View already, but in the pediatric, we will soon have it here in Las Vegas. Right now, we've had to refer out to mainly California programs for them to get this therapy. But again, it is FDA approved. It just takes a lot of, again, legwork to make it happen. But yeah, so these therapies are really cool because you actually take T cells out of the patient and you put them in a dish and you make them grow and you add some stuff to them, and then you actually transduce them with a virus. And so T cells are the cells that naturally are in your body, and they exist to protect you against viruses and some bacteria. So like you might have a T cell that's ready to go attack the influenza or ready to go attack COVID. And now you're taking these cells and you're putting another virus onto them and saying, don't attack COVID, don't attack the flu, you need to attack the leukemia cells. And so you're kind of retraining them to attack leukemia cells. And then once you've retrained them, then you inject them back into the patient with, again, the hope that those T cells are going to go attack the leukemia cells. And so that's, like I said, that's some relatively new therapy. And they're using the same approach, not just for the leukemias, but they're trying it for a lot of different solid tumors as well. But still, again, very early for those type of applications. But for leukemia, we're on the way. So, and then the last set of slides I wanted to just comment on. I gave a talk at the Cancer Control Summit, which was a meeting a few weeks ago. And the title of that talk was Recognizing Signs and Symptoms of Cancer in Children and Adolescents. And really the point of that talk was what I alluded to, is separating out normal symptoms from cancer-related symptoms, okay? So the other important thing to remember about all the scans and all the blood tests that we do, and I kind of alluded to this too, is that you may not see any cancer, you may not see a tumor, you may not see cells in the blood until the cancer has advanced to a certain point, okay? And so, like, even when we do these PET CTs, which are kind of the best way for us to detect active tumor cells, you still need 1 million cancer cells to show up on this scan. So in other words, if you have less than 1 million cancer cells, you might see a normal scan, even though there's still cancer there. So then the question would be is, can you detect cancer earlier? And so that's a big area of research. And, so you have a big population of normal stuff, but where's the cancer cell? And again, complicated diagram. No one's supposed to remember this, but it's just, again, to show you that there are a lot of different ways we're trying to detect cancer earlier. And it's really this list here of things that we're, trying to figure out is, can we detect different little pieces of DNA in the blood that suggest cancer? I mean, we're already getting to part of this. They have Cologuard advertised on the TV to detect colorectal cancer DNA in your poop. So, again, all of these things are being made. And, the question would be, can we integrate this into pediatric cancer detection? And I just wanted to point out, there was an article that came out last year titled this, Early Detection of Childhood Cancers. And it was a review calling for research directed at early detection of childhood cancers. And they give some reasons for why they think we maybe could do this. But they start out by saying the reasons why we can't do this, okay? And so these are the reasons that people have said we shouldn't screen for childhood cancer. We say that they're too rare to justify screening, that they're too aggressive, they come upon too quickly, so the diagnostic period is too short, that even catching childhood cancer early will not lead to better outcomes, that risks of screening are unacceptable, and that screening for cancer is not economically justified. And then this article actually goes through each of these arguments and argues against them. So it's actually a very interesting article. And so I'm not saying whether or not this is going to be applied or not applied, but they offer some kind of suggestions about how we could start to at least talk about screening earlier for childhood cancers. And again, there's still the fact of the matter is we don't really know what causes cancer. We know there are some genetic predispositions, and we know that there are some environmental exposures that may predispose, but we still don't really know what causes childhood cancers. And in fact, we still don't really know what causes most adult cancers either. So again, just to plant those philosophical thoughts in your mind, but because I mean, I think more thought about this is going to be up and coming, because very soon, every single infant in the state of Nevada who's born is going to have their whole genome sequenced. In other words, we do newborn screening right now, and we check for a bunch of different newborn screening diseases, but pretty soon everyone's going to basically have a 23andMe done on their baby, and that's going to be standard newborn screening. And I think we should do that. So we have all that data, and then the question is what do we do with that data? And of course, we're going to still make diagnoses of sickle cell anemia and congenital hypothyroidism and all the other bad genetic diseases that get screened for on the newborn screen. But there's going to be a whole bunch of other data that we collect as well. And some of that data is going to be like, well, if this baby has mutations in these genes or changes in these genes, they have a 5% risk of getting leukemia in the first 10 years of life. And then we're going to have to figure out, so how do we, what do we do with that information? Do we check blood counts every month? Do we, and so those are, again, philosophical kind of questions that we're going to have to deal with pretty soon as we get more and more detailed genetic testing on our population. And so this was another article where this was from about 8 years ago now. They actually did screening for leukemia translocations in newborn infants, in all newborn infants. So these were healthy newborns. And 5% of them actually had a translocation that's associated with leukemia. But obviously 5% did not develop leukemia. In other words, a very small percentage of these kids would get leukemia because it's a rare disease. However, 5% still had a change that we would normally associate with leukemia. And I mean, I think the main answer is obviously that's not a good screening test for leukemia because, it happens in normal newborns too. But it still begs the question of if we're going to use, genetic DNA to figure out is someone at risk for cancer or not, we still have a long way to go to figure out what the right testing is to do. Okay, so in the end, for parents in the room, for grandparents, for soon-to-be parents, I think if you have a child who's sick, I think you just need to do your best to keep the symptom diary. In general, in oncology, we say cancer doesn't get better. In other words, if you don't treat cancer, it's going to get worse. So leukemia doesn't get better on its own. And so if they have a fever and it goes away and they're fine, it's probably not leukemia. But if it's lasting for 10 days and it's not going away, I think you need to know their symptoms, trust your instincts, ask for reevaluation if symptoms persist, and then obviously be an advocate for your child, which all of us are going to be. And then finally, some take-home messages. Cancer is rare but deadly if missed. Symptoms are subtle, but again, are persistent. In general, early recognition equals better outcomes. And then finally, we all play a role, families, physicians, the community, knowing, that even though cancer is rare, it does happen. And we're now, a population center of near 3 million people. Our pediatricians are going to see cancer happen in kids. And there's my 2 troublemakers, 2 high schoolers now, very dangerous. And then my Chicago sports teams, the Cubs are doing okay. The rest, not so good. And this is where we work, and feel free to email me or look at the website.
Okay, do we have any questions for Dr. Lasky, either on Zoom or in the audience here? We'll have to give you the mic so the recording can pick you up. Any questions? I have a question.
Yes.
How do Nevada's pediatric cancers compare to other states?
For the most part, we're pretty middle of the road. In other words, there's not really any increased risk for one or the other. I trained at UCLA down in Los Angeles, and there always seemed to be a little bit of a spike of leukemias from the Bakersfield kind of rural central area. But again, there really was no single causative thing found, in those areas. And obviously we are not that far from some atomic test sites that happened in the long distant past, but again, haven't really found any true peaks of cancer incidence here. But so we're pretty, middle of the road or equivalent with the rest of the United States with regards to cancer incidence.
Is Nevada the only state that does as soon as the baby is born, test?
So we haven't done it. It hasn't been implemented yet, and I think it's only been implemented maybe in two other states, like two states. Like, well, it's just up and coming. Yeah. Mhm.
But may-
So really good question, and I know in my complicated picture here.
Could you repeat the question, Dr. Lasky, for the
Oh,
recording?
sorry, it
for the
was about
recording?
how AI is going to be involved in early detection. And so it's at the bottom of my slide, I have advanced machine learning down there. But basically, I think it's going to be a very powerful technique to help evaluate this complexity, because that's the thing. The human brain can't do this by itself. And I think it's going to play a big role in integrating all of the data that we have and making predictions. And I think its role is going to be, again, it's still going to be prediction. It's not going to have an absolute answer, but it's going to be the risk of you having this is 5% or 5 to 10%. And it's going to give us those kind of numbers. But still, that's going to be more than we have right now.
Here's a question.
Hi, I was wondering if you think that what the risks will be associated with genomic mapping done on every newborn patient, because my mind goes to insurance companies, and I just wanted to get your thoughts on that.
So yeah, so those risks are there, and we're going to have serious discussions about what kind of information is released to insurance companies. And that's all there is to it. I mean, at this point, I would hope that genomic DNA belongs to the parent and the child only, but obviously it's out there. So, but no, those are very good questions. I mean, we already have some of those issues come up right now where, if you have a 14-year-old girl who has a mom who had breast cancer when she was 30 years old and has a BRCA mutation, is that 14-year-old going to have problem getting insurance when she turns 18? So it's already started about difficult questions surrounding that. And I don't have a good answer. I think we need to have policies and discussions in place when that happens. So,
Dr. Rodrigo, do you have any questions? No questions today. Anybody else? Let's check our Zoom one more time. Doesn't seem like there are any questions on Zoom. Okay, just one more round of applause for Dr. Lasky. Thank you so much. There's a flyer outside for you can look at for future events. Please grab it on your way out. You did a great job.